Thank you very much for the invitation to speak here again, and it's a real pleasure to do this talk again. But in the 6 months that I did it the last time, so much has changed. This is such an incredibly fluid field, and I think we are moving in a really exciting direction. That we will be applying AI, and the question is how, and how will this affect you and into the future? So I'm an intensivist, and what is an intensivist? So it's a doctor that takes care of critically ill patients, and that generally means you have an organ failure. So one of your organs has failed, but it also means that if we don't treat it, you're very highly likely to die. But we also can bring you back from that death, that we can apply interventions that are able to reverse that pathology. We want to provide safe, effective and timely care to patients so that they suffer less because of that. And we unfortunately provide extremely expensive care. The care we provide really involves high-stake decisions, but also it is a technologically rich environment. So we like to try and measure everything to try and figure out, A, why you got so sick, and B, how we can get you back from that. And as an entity, ICU is something that has been developed over many, many years. In the first place, in terms of how we deliver the care, is that we cohort patients. And this was something that was brought in Crimea. And cohorting patients sounds pretty sensible, that we take the sickest and leave them together. But back in the time of the Crimean War, you were cohorted based on rank, which wasn't particularly useful. And Florence Nightingale recognized that if you wanted to get the best efficiencies and train the best nurses, you had to have the sickest patients in the one place. And the next big breakthrough for this was cohorting expertise. And Walter Dandies was a famous neurosurgeon in Baltimore at the turn of the last century. And he wanted only the best doctors, only the best nurses working both during the surgery and afterwards. And with this kind of improvement in administration of how we manage hospitals was also technological advances in how we deliver care. And this paralleled scientific and engineering advances at the time. So anything that was being developed in science, doctors are often very quick to adapt and adopt it into their practice. So positive pressure ventilation was used to save children's lives during the polio epidemic in the 1950s in Denmark. This is a mainstay of how we treat patients today. Point-of-care testing, so this means that we know exactly what the physiology of your blood is at the bedside, and this can allow us to make sure your heart is under the optimal condition to get you back in a better place. Continuous cardiac monitoring, extracorporeal membrane oxygenation, these are all things that we apply, and we apply correctly at an evidence base to provide the type of care that took us from one pandemic, and you can see here people in iron lungs for the polio epidemic that had happened in the 1950s and 60s, and thankfully because of vaccination we don't have to face today, to the COVID pandemic that we had, where ECMO and proning and all of these really advanced technological maneuvers were being applied. So the care that we provide is an extremely data-rich type of care. And this was something that was brought into the first, what we would probably recognize as being an ICU today. And this is as far back as the 1960s. So the shock ward, as it was known, in the Los Angeles County Hospital in Southern California, recognized that huge amounts of data needed to be processed and understood to really get to the physiology of the physiology that the patient was suffering at the time. And they incorporated computers. So you can see here in this patient in the top left-hand corner that anywhere they can be put a transducer can be put, a transducer was placed. And that data was monitored in a specially designed computer at the time. And they'd get a readout like this in the top right-hand corner. And it looks pretty tricky, but nurses and doctors will pore over this to try and get the trajectory of what aspect was wrong and what could be turned around and what interventions could be applied to the patient to take them out of that shock state. And what I thought was quite interesting when I was looking at it was they had this P of S. which you can see up here. So that's probability of survival. So they used the data to create algorithms as far back as the 1960s to say likelihood of survival. And you can see here every day he's 1. Let's hope he doesn't go to 0. And I thought it was quite funny that doctors would look at, oh, it's 0, and will that push me to not intervene? And how good is that data? So again, showing that as doctors and as physicians and nurses, we've always tried to use data to try and tell us where this patient is going. So this isn't new to us. And in the patients that we do see, they often produce an enormous amount of data, even before they come to ICU, because they're sick and people recognize that something needs to be done about it. And certainly as soon as they hit us, we start generating an awful lot of data. And just to give you an example of what we're looking at, so this would be just one screenshot from a patient in the ICU, and the top right-hand corner is the mechanical ventilation data. We take minute-by-minute breaths, and these are recorded, and the nurses will validate them. So we need to know how high the breath is, like how much volume is going into the lung, because that actually makes a physiological difference. And we align that with the laboratory data, so we take very frequent measurements to see if these are actually aligning properly. And this data is an incorporation of sensor data, imaging, laboratory, and in our minds as doctors, this is what we're wanting to do. And it's a whole field in itself to try and manage where this data goes, how it gets used. And it's not just for the patient, and I think this is an important point. The data we generate provides benchmarking of how well we're doing. It tells us whether we're an underperforming or an appropriately performing intensive care unit, if our mortality is standardized. So this data is hugely important. And every ICU in the world generally produces a large volume of data. And this has been fueling major advances in how we understand disease pathologies. And electronic health records in the US have been used to develop these things called open access data sets. So MIMIC was one of the first ones. So this is the Brigham and Women's Hospital in Boston. And several years ago, they decided to make their data anonymized and fully accessible. So any researcher in the world with appropriate credentials and appropriate kind of understanding of the data can go in and start asking questions. And that was followed suit by the electronic ICU database. And this is a huge opportunity for computer scientists and physicians to work together to try and figure out the pathophysiology of disease and understand trajectories of diseases. And this is just, at the bottom is a kind of a diagram of the number of citations related to this over the years. And you can see there's an enormous scientific output from this work being made available. And in the bottom, we actually have the Amsterdam. So Europe, again, has lagged behind, certainly, on making this data available. But the Dutch have done that. And we can see that there's an increase year on year of the output of this data. And I'm going to talk about why it's important that we have representative data, because if everything is coming from 2 or 3 major ICU hospitals in the US, that's not really that particularly representative of what we're doing in the rest of the world. And just to kind of give you a flavour for what actually comes from these data sets, like we can understand better the effect of how we deliver ventilation. We can try and prognosticate who's going to get sepsis. We can incorporate what's happening in the chest X-ray with the physiological data that we're deriving from the notes. And in terms of, ICU, it does save lives, and if the data that we're generating tells us how to save lives, then that's wonderful. But I would caution to say that we're not quite there yet. So if we're going to use AI on our current data set, it hasn't got us down to the mortality that we really want. 60% of patients who will develop severe ARDS will still die. And these are patients that we would anticipate have a chance to live. So we have improvements to make, and we need to continue to make data available into the future for researchers, both computer scientist researchers, biomedical technology researchers, and doctors, so we can work together to make better decisions for our patients. And we are in ICU in a really favourable position to use data very effectively, because we have 3 things. One is we've machine-generated data, and we create a lot of it, from just the physiological measurements we do on patients to the x-rays that we generate on them, and everybody gets a CT scan because we can't make a decision without having an awful lot of data. It's one of the problems we have as ICU consultants. We also document a lot of clinical impressions. So when we come in, we write notes and we say, we think this is what's going to happen, this is what we're going to plan. If something bad happens to the patients, we contextualize a lot of that physiological data. And then we have many and multiple outcomes. So we have small outcomes. So the patient, in response to an intervention, may drop their blood pressure. That's an outcome. The patient may take an X amount of days to come off the ventilator. That's another outcome. The patient may live, the patient may die. And all of those things are really, really important if you want to train data sets to what is actually happening. So, and the other thing that happens nicely with ICU, it all happens very quickly. Our attention span is usually to 28 to 90 days. So if you're considering going into fields of like diabetes, that's 30 years. We're 28 days. Very short attention span, but it means that we work round the clock and generate an awful lot of data. And not surprising in this context, the ability to apply AI, to use our data better, has paralleled the number of citations coming out of it. And particularly this whole idea of, using our clinical notes to try and contextualize what we're doing to the patients. And with breakthroughs in natural language processing, the number of citations related to this has increased enormously. And here in Galway, I'm going to describe maybe a few of the studies that we've done and kind of give you a context of what it's like to, one, use this data, and two, where I think it's going to bring us. And last year, we published this paper on using notes that we generate in the ICU to see if we can just make it a useful summary. And this sounds like a fairly straightforward, easy enough thing to do. Now, one of the problems with people writing notes in Irish and European hospitals is that we're not doing it for billing purposes. So nobody is going to go over in notes and say, you didn't write everything in, therefore we're not going to get the amount of money we want out of that patient episode, because that's actually what happens in North America. And it's an interesting problem because it means that the notes are terrible, but if they're ever written, they usually say something very important, either that will protect the patient or protect the doctor from the coroner, one or the other. So that's, and that is kind of an important contextual bit of information. The nurses are much better. They write really, really detailed notes, and usually I'll read what the nurses write before I read what the doctors do. But we wanted to see that if we pulled out all of this data at the end of a patient's admission, could it produce a useful summary that would be better than what the doctors write? And I always knew it was going to be better than what the doctors write, but if I had to actually show it off to a group of non-medics who would still want to have some confidence in what we do as doctors, that they would say, oh yeah, that's good. So what we did is we had to then go through the regulatory process for accessing this data. So one of the other problems with ICU research, and it's not a problem because I think it does make us really focus back what we're doing on the patient, is that we actually usually can't ask the patient for permission. Patients are usually unconscious. They don't have capacity, so we have to ask family members. And because we were going to take their data and literally put it onto a cloud and ChatGPT, we had to wait for patients who had regained capacity and say, look, you've just come out of ICU, you've been pretty sick, we wrote loads of notes of you. Are you okay that you're involved in this experiment where we're going to see how well can ChatGPT and other different large language models, go through your data to summarize it? And they all actually said, well, as long as they're not able to recognize me. And we said, well, look, we're going to go through your notes very carefully, remove any identifiers and any kind of dates, and make sure that you wouldn't be identified. And they were happy, but they were very clued in to, what are you doing with my data, doctor? And I think that's the right way, and it was very good feedback for us that this is an important aspect to patients. So we took a training set, and then we also kind of developed the prompt structures, and then we applied it to a set of different patients. And you'll remark it's quite a small number of patients, and I will talk about why it's such a small number of patients, because doing this, one, it was a short project and we didn't want to apply too much time to it, but two, it's actually hard to get patient data in Europe. It's quite tricky. And what did it produce? So this is one, and was kind of a good example. There's quite a complex patient. A lot of these patients had been in for weeks, and some of the patients had just been in for days. And one GPT summary was able to, if you read it, you can see that it's providing quite a bit of detail, and kind of important detail. The patient got a pericardial drain. That's a drain into just around, the lining of the heart. They had an obstructive tumour. The other one says they have cancer, and I'm going to give them some olanzapine. So one's really good, and I would say that's a pretty good one. The second one, not so wonderful. And it probably tells us that it hasn't been trained on notes written by Irish doctors, which is very true because it really hasn't been access to it. So it's not used to, the way that we write. It did much prefer the nurses' notes because they give lots more details. But we had to say that the fact that you turn the patient to the bed is probably less important than they have cancer. So please, bring that down in terms of lists of important things to mention. But what we asked a set of senior doctors when we asked them to review this was, give your impression of their overall ability to identify a predefined list of important clinical events. And we considered these are important things that happen to the patient and they should be mentioned. And even the best of them only mentioned about 40% of what we consider to be clinically important. The readability ranged quite a bit between all of them, and the readability being a problem, and the organisation. And this is a really subtle thing. So what you do to the patient and how you relay that information changes all the time. So turning the patient for a prone position because they're have extremely low oxygen levels is very different from turning the patient in the bed. And the computer to be able to understand the differences, the nuances, the context of that will probably require a lot of training. And we were asking these systems to do it, having never really been exposed to the Irish ICU data set before. And this is kind of the feedback we got, and it reflected that there was a lack of coherent storytelling. It wasn't able to tell the story of the patient really, really carefully so that you'd understand where they're coming and where they're going. There was inaccuracies and omissions of crucial details. They weren't able to tell what was going to be clinically important to the patient. And there were some proper hallucinations saying patient discharged on vasopressors. Like, you can't physically give those on the ward, so that was incorrect. The other two didn't hallucinate because they didn't actually give you any detail, so they actually weren't even able to pull together a proper summary. Now, there's been an explosion of publications related to large language models in healthcare, and we're really excited, and I do believe this is going to bring in change because we can fix all of that as we do more work. But a recent systematic review, and this was only published last year, looked at 519 publications. Only 5% actually used patient data. So, the promise is there, but we have to bring it to the patient, and we have to train it on patient data sets. And we know that large language models are going to be hugely important for diagnostic formulations, for treatment planning, for medication recommendations, for clinical documentations. But if we do not test it on real patient data, on real-time events, we're going to change, and we're not going to be able to trust it as well as we should. And it may hallucinate. It may provide inappropriate treatment recommendations if we don't really carefully train our doctors to look at it critically. And there are a load of recommendations, a paper in JAMA that was again published in the last week or so, saying that we will have to change how we set up medicine to be able to incorporate this, because it is going to help us, but if we don't design how we bring it in, we're going to be in trouble. And it is coming. And that, I think, is really important, that, once something is useful in medicine, is we're very, very quick to adopt it. So in China, 300 hospitals have already implemented DeepSeek on their hospital servers, and it's being used for patient diagnostic and decision support, education, scientific research. And this is just, again, from the last, I think, last month, looking at the number of hospitals and downloads in Chinese hospitals of DeepSeek, and in the blue bar, the number of hospitals that have implemented it. But there will be problems with this, because if you over-rely on this and it hasn't been trained on the data set you're looking at, you might get diagnostic errors. And I'm going to give you an example. There are not many 20-year-olds who ever get septic shock. Okay, it's just really uncommon. It's much more common that it's a 60 to 80-year-old. And the physiological data sets will be trained for that 60 to 80-year-old. If you apply them to a 20-year-old, you may get the wrong answer and you may do the wrong thing unless you consistently test for it and unless you consistently enrich your data set for that patient. If we don't apply this to all populations and include all stratas of society, including poor populations, underserved populations, we're going to be providing care that is going to be very biased. So AI, I don't quite see it replacing the thinking doctor, because I think what we do, it is deceptively complex, and particularly if it's done really well, it looks really easy. But incorporating the time of thought, how well what was the decision making and how that changes. So at 4 o'clock in the afternoon, doing one set of tasks in one order changes as the night goes on and staffing availability is not so available. Prioritizing, so how are we going to get AI to understand what's the right priority to do? Is recognizing pain and delirium as a cause of sepsis, or pain and delirium as a cause of withdrawal from drugs. Can it detect those things? Because a doctor coming in who's experienced will pick it up very quickly. A junior doctor mightn't be as quick and has to learn the hard way. And how are we going to take AI from being kind of a rubbishy junior doctor to being a really good senior doctor, and how do we train that? And it kind of brought me back to, well, where have we had very large telecommunication-related innovations? And I think there have been many probably in the last 100 years, but I thought the telephone was kind of a good place to start. And this is a really, if you're very bored, reviewing on all the letters written by doctors complaining about the telephone when it was first introduced back in the turn of the century. And some of them was the effect of consultants didn't like that they were now called at home. This is a terrible thing, and they said, down with the telephone. But the first telephone call was actually a call for first aid, because Mr. Watson was being told to come because Alexander Graham Bell had spilled sulfuric acid all over himself. But it really did enhance how we provide care. It enhanced coordination. So rural hospitals suddenly had a direct connection to major big hospitals. It improved resource allocations. If one hospital was completely overfull, they were able to phone other hospitals very quickly and shunt critically ill patients to other ones. And it certainly was good for patients. And it was the start of improvements in technological advances. And this is kind of an interesting picture. So President Andrew Garfield had been shot, and Alexander Graham Bell knew that if you put the telephone near metal, you'd get static, and they actually were trying to use this to find the bullet, and they weren't successful, and that's more down to the surgeon who didn't know how to use it. But just to kind of, say, like, well, where are we with the equivalent of the telephone as we are now? And this is a survey from the American Medical Association on how rapidly doctors are taking this on board. So in 1 year, people's familiarity with translation services, billing services, assistive diagnosis, automation of insurance pre-authorization, triage and case prioritization support, all of these, every single one of these are things that AI are absolutely going to use. I looked through the list and I said, yeah, that's super simple. That's super copped on. But there are risks from AI in medicine, and I think if we don't recognize them, we will run into problems and we will run into trust. So multi-agent miscoordination, what's that? So that's where you have one AI system saying, do this for the lungs, another system saying, do this for the kidneys, and they start going against each other. Conflicting objectives from fragmented systems. You've got one thing saying, oh, don't admit that patient, he's going to stay for 50 days because we know on his previous hospitalizations he stayed in for a long time, and you might have him shunted to another hospital. Collusion. So they collude together to make doctors use a more expensive brand. And if you can get into, the background data, you could probably do that. Network effect. You have one thing that worked really well in one hospital, but it doesn't work well anywhere else. But because AI says it does, it gets propagated, maybe inappropriately. But I'll make the effect. These already exist in medicine. Okay, and we know there's collusion amongst doctors. We know there's information asymmetry. We know that we can very rapidly have network and error propagations. And we have things like the medical councils, whistleblowers, newspapers to really highlight, look, medicine and doctors aren't perfect, and the systems are sometimes, not wonderful. And if we recognize that as doctors, add AI to that, we do not want to magnify those errors. And what we need to do is recognize early on that regulation is, and I'm telling you as somebody who's had to do an awful lot of GDPR-related work, it's a pain, but it is going to protect you. And understanding the need for oversight committees, and you can see I've written it twice, so I should have had somebody oversee my oversight committee, but governance, coordination, risk audits, they're all boring stuff, but we have to build it in. And perhaps with the help of AI, this will make it easier that we recognize earlier what are the problems we're going to come up against. And we're going to be dictated from a healthcare sector that's very different from what we practice in Europe. Okay, all of the AI-related work has been in the US, and the one paper that we did, and we're hoping we'll do more papers. When we were doing rebuttals for many times the reviewers wanted to reject it, was this is not being done in Europe. Any related data that actually asks patients to put their data through large language models are all predominantly coming from the US. And that's because we have an awful lot of regulatory hurdles to get through. But I'll argue that, be very careful throwing out regulation, because it will protect us at the end of the day. And having to deal on a daily basis with people who are caring for really sick patients, so families who are coming in, managing their loved ones that are near death, it sucks all your energy out of you. So if that information that we generate as doctors is going to be used against them in the future, they're already on the back foot, okay? So if automated decision-making recognizes them as somebody who had COVID and we're now not going to insure them into the future because of that, or we're going to provide restrictions on where they go in the world, or there's going to be some kind of bias against them, that's completely not appropriate. If we're going to automate claim denials, and this is already happening. So I don't know if any of you guys follow Dr. Glaucomflecken on YouTube. He's quite entertaining and he's very astute with regard to how medicine is practiced. How is that possible to do 300,000 claims in a week? Automated it. And that's 300,000 people's lives. It's like 300,000 claims means that 300,000 people had medical problems that they thought their insurance company was going to cover, that they probably should cover, and they're saying no. Okay, and so that means 300,000 people are left going, where am I going to find that money? And they're already, the most common reason to go into bankruptcy in the US is healthcare-related issues followed by divorce. So don't get sick and don't divorce seems to be the bottom line. But trust. Okay, so trust versus regulatory arbitrage. And and I did put a lot of kind of thought into this over the last 6 months, but I think people remember Napster and Kazaa, these were a bit dodgy, and I think at the end of the day, people didn't really feel comfortable using dodgy equipment because you felt like your phone was probably going to get infected with all the weird stuff, and then they started kind of basing their tax offices somewhere in the Virgin Islands in Jamaica. So people will go with trustworthy, upright companies. They feel a little bit safer for it. And I think it's going to be the same for who you want your knee replacement done by. You don't want it done by somebody who's a snake oil man, and that's the truth of it. So if we won't listen to dodgy, streaming music, we shouldn't want the same for medicine. And I think that, regulation is important, and companies that say we're going to break the rules to establish a foothold in the market, and that happens, or we're going to do all the studies in places where the ethical guidelines aren't quite as good as they should be. I think they'll ultimately fail, and they should ultimately fail because it needs to be done correctly. And I'm going to kind of finish up fairly soon, but in the US, there's multiple ways, because they do recognize this is going to be a problem and it is going to hurt people if it's not done correctly. But AI needs to be tested by real clinical impact, not just technical specs. So one of my side jobs is I do a lot of clinical trials in the ICU, and again, that is going to be absolutely crucial, that when we're applying AI, that we test it on its clinical effects, not on how shiny and how quick it looks. We need to integrate how it's going to change how we practice medicine, so that instead of just accepting this load of data, looks really nice, it's written really nicely, it's better than what the SHO used to write, but if it omits clear and very important information on the patient needs to be anticoagulated, or the patient should stop their antibiotics, or they're allergic to something, and that's not included, that's a major problem. We need robust governance, because God knows if doctors can get away with something, they will absolutely do it. There's always a subset of really, really people who are just out for profit, and medicine is not immune to it, and we need to recognize that. And that's why we have the Medical Council. If the Medical Council needs to bring in a subsection on how to deal with AI and how to make doctors responsible for their behaviour, then that's what it has to do, and we have to think about that ahead of time. And we need to also be adaptable. The rules we make one year might be obsolete the next, and we need to move with that and stop having that, like this is how we do it, and GDPR can't possibly change. It may need to change in line with practice, but we also have to advocate for that. We need collaborative benchmarking, and we need to educate people about how we can apply this data. And if it's good, we go with it, and if it's bad, we recognise how it can be removed. So needs musts. If technology using AI saves lives, we will absolutely adopt it. I worry that we're maybe a little bit behind in Europe, but I think we've got a bit of breathing space with the craziness that's gone on over there at the moment. So we should take it and try and drive through as much SMEs that are comfortable and confident to apply this technology and work with doctors and hospitals. We really need to link engineers and medics, because I do believe we've worked together really, really well to bring ICU to where it is. And I believe that if we continue to work together, we can streamline and improve the care that we do. And I'd really like to say thanks to the patients who were involved in the research, and it's a major privilege to ever do an intervention that makes people better. You feel really proud, but you're never doing it by yourself. It's always part of a team. And this was I was on a talk during the week. So medicine is basically people giving lots of fluid, taking expensive pictures, and taking the fluid out again. And that is probably slightly true, but at the same time, I think we hope we'll make people's lives better. So thanks very much.
I think that we actually have time for one question or two, if anybody has any opportunity to grab Bairbre while you can.
Stone silence. You're very safe in the ICU in Galway, I'll just tell you that.
Sorry. Just wondering, would you think insurance companies should get involved while you're testing this AI models? Should insurance companies have some indemnification for
and that's exactly the question at the moment. So it's like, whose fault is it if it goes wrong? And we had like an EHR company saying during the week, we can't possibly put up warnings because we'd be indemnified. And I was like, what? Like your EHR standard is that it'll actually tell you if somebody has sepsis and please institute a bundle. And they're like, oh no, we can't do that. And I just knew they're kind of selling an inferior product, but I was like, no, that's standard. And so yeah, at the moment, there's no rules on who will take the blame if something's not followed correctly. And I think it'll fall down to the doctor, whoever institutes the treatment. And I think at the start you may have people saying, it was AI, but I strongly suspect anybody who's got to a point that they've got a company that's going to be applying a treatment, it'll go through the medical device regulated stuff. And unless you can find collusion at the back end where people are going out of their way to do it, or you develop a disruptive product. But at the moment, this is why we need clinical trials, and this is why you do, your stage 1, stage 2 trial, and you have, meaningful outcomes, and they're so critically important. And I also think AI is going to just streamline how we do clinical trials, and that if you come into a hospital, you should expect to be in a trial. If you've got, I hope nobody has to go through cancer, but if you want to be in a trial, because that's the best treatment, and that is pushing the field forward. But it also means that you've extra people looking at you. So your answer to who takes the blame, I suspect it'll be the doctors, but it's all up for play.
Hi, I'm Tanmay Jagtap. I'm AI engineer from Biomedia. So my question is, there are some reasoning models currently in development, agentic models, which gives the reason behind their actions and their responses. So are these agents more reliable, or how are we progressing in that direction? Because they are useful in the coding base or like any technical stuff, but how do they mean to the medical terms?
So they would be incredibly useful. And anything that I've read on this recently was trying to, determine where somebody would look to find a hairbrush. That was kind of like an example used. There's no such thing, no such studies being done in medicine at the moment. And I think the problem is that we don't have access to the data. It's not being made available. So, and one of the things about medicine is that there is a lot of hierarchy, and it's not necessarily the consultant. It might be there's a really good senior nurse, and they tell their kind of, junior nurses what to do and when to do it. And sometimes following the exact code book and the protocols and the guidelines might be completely wrong for the patient at that minute. And I don't think, I don't think we're studying that type of, when should you do exactly the right intervention. It is wide open to do that, because ultimately if we can get a robot to do what we wanted to do, we'll be doing great. I will say that a lot of the medical devices, so if you dialysis machines, mechanical ventilators, they introduce things like size every few minutes, and they're given like every 15 to 30 minutes. And a lot of people just turn off those features because they're so rigid, and they haven't worked into what the patient's natural rhythm is. And I think things like that will improve how we deliver the care within medical devices. But I think medical device companies are still a little bit scared to make and put those devices online, like the security risk from it, from just bad players or being broken into and somebody ruining a reputation because of messing with the code is really, really high. But you're right. They're the obvious things that I think will improve how we deliver care. But it will be a difficult road to get it implemented into medicine. But if it works, we will use it. Thanks very much.